And good afternoon, everyone, and thank you for joining today's presentation. Please take a minute to orient yourself to our platform. If you would like to ask a question, please use the chat feature in the lower left-hand side. Technical questions will be addressed as they come in, and content questions will be addressed at the end of the presentation. If you'd like to download the slides from this presentation, please use the icon at the top right. Additionally, live closed captioning is available at the bottom of the screen. My name is Chris Duff, and I am a disability practice and policy consultant who has been working with the Lewin Group to develop the disability competent care model and related webinars and materials. Today I will be joined by Dr. Judy Chamberlain, Senior Medical Director for Aetna Medicaid. Dr. Chamberlain received her BA and MA degrees from Stanford University and Dartmouth Medical School, respectively. She completed a residency in family medicine in Bangor, Maine, and has been board certified in family medicine since 1980. She practiced family medicine in Maine for 30 years, including her 3-year residency. She is active in the American Academy of Family Physicians as a past president of the Maine chapter and nationally as a member of the Academy Board of Directors. At Aetna, her major area of focus has been integrated care management programs, which includes chronic condition management, perinatal care management, and long-term care management. She helps to develop clinical programs for Aetna's Medicaid members with particular emphasis on biopsychosocial approach to each member and to fully integrated physical and behavioral health for all members. Additionally, she is a board member of the Institute for Medicaid Innovation, whose mission is to improve the lives of Medicaid enrollees through the development, implementation, and diffusion of innovative and evidence-based models of care that promote quality, value, equity, and the engagement of patients, families, and communities. I'm truly honored to have her provide this presentation today. On behalf of the Lewin Group, I would like to welcome you to our Disability Competent Care webinar series. The Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services has contracted with the Lewin Group to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees. This series will consist of 7 webinars running on Wednesdays at this time through March 22nd. All the webinars are being recorded and will be available along with a PDF of the slides at the Resources for Integrated Care website. In 2013, we published a comprehensive disability competent care self-assessment tool describing disability competent care, and has since produced 25 webinars on the topic, along with numerous supporting tools and documents. These are also available on the RIC website. The DCC material has recently been revised to be more accessible to users and reflect the further development of the field. It is now structured in 7 pillars of disability competency. In this series, we are introducing the 7 pillars with a webinar dedicated to each. We will be allowing at least 15 minutes at the end of each presentation for discussion and questions. As you can see in this slide, today's presentation is on the 4th pillar, primary care. We would like to solicit your opinion on this series as well as past webinars and supplemental resources. Please take the time to complete our survey at the end of the webinar and send us your ideas for future topics and content. Contact information is listed at the end of the presentation. The delivery of disability competent care in a primary care setting is a collaborative effort. It involves a participant-centered approach to primary care as part of the interdisciplinary care team. Particularly for participants with disabilities, primary care involves maintaining health, preventing or managing common secondary conditions, prevention of avoidable hospitalizations, and establishing transition protocols to mitigate difficult changes. The responsiveness of primary care is often the key factor in reducing emergency department and inpatient utilization and costs. A key to capturing this opportunity is the timeliness of the availability of primary care and the communication between the primary care practitioner and the interdisciplinary team. At this point, I will turn the presentation over to Dr. Chamberlain.
Thanks, Chris, and welcome everybody. There is a ton of information on the slides that have been put together for this presentation. I will not, in the interest of time and in the interest of not boring people to death, I will not be reading all of the slides today, but we'll use them as a background for my comments. So if we go to slide 7, who are we talking about? We're talking about people with physical or intellectual disabilities or disability due to serious mental illness. Words matter. Words matter a lot. Using people with, not a disabled person, a mentally ill person, but people with a disability reminds us that people aren't defined by their conditions or their disabilities. We also know that people may belong to 1, 2, or 3 groups of disabilities and non-disabilities. Disabilities aren't always obvious. And that's a problem, but it isn't up to me to decide if I think somebody who doesn't, in quotes, look disabled has a disability. And it's also not up to me to decide how limited somebody's life may be by a visible disability. But these happen to people with disabilities every day, particularly in medical practices. Next slide. As a primary care doctor, as a family doc, I needed to be aware that people with disabilities do experience delays in routine care, might not get recommended care at all. We often don't think about health education or really critical screening, cholesterol, diabetes screening, mammograms, pap smears, all of those things are often missed in the kind of confusion of caring only for the critical pieces of somebody's disability. As PCPs, we need to be careful not to assume that a new patient with a disability has had all the appropriate age and gender routine care. We know that people with disabilities have difficulty getting to care and may not have been asked the appropriate questions, and we'll talk a little bit more about that in subsequent slides. If we go to the next slide, which is called social factors, these are really more health systems factors than social factors. Things like value-based payments, which are critical in improving health care. They have a goal of improving quality and efficiency of care and also obviously trying to control costs. But it may be harder to achieve performance measures associated with value-based payments in patients with some disabilities. So providers, particularly in a large, busy primary care office, may choose an easier route. They may concentrate their efforts at maximizing the measures for which they get enhanced payment with their non-disabled patients, because that's the majority of their practice panel. This, in patients with disabilities who are also dually eligible, have Medicare, Medicaid, becomes even more difficult in a value-based model because of the complexity of coordinating which benefits, which care, quote, belong to Medicare and which belong to Medicaid. So it becomes even more complex when you have to coordinate not just the care but the payment. Next slide, we're going to start talking about delivery of care. And the key on this slide is participant-centered approach or patient-centered approach in my lexicon as a family doc. This is not unique to disability-competent care, but it is so critical when you're working with someone with a disability to recognize who they are, not just what their disability is. On the next slide, we look a little bit at the challenges in primary care. Truly competent care for people with disabilities does need a team approach. In traditional primary care, it is at its worst fragmented, episodic, poorly coordinated, suffers from poor information sharing among providers of care. As patient-centered medical homes and behavioral health homes have become more common, they have encouraged more coordinated and even co-located care that's much more patient-centered and involves all the members of a person's care team and their circle of support. When you move beyond that to a fully integrated system of care, which is something that we are working very hard on as a Medicaid organization, it means that the medical, behavioral providers, personal supports, ancillary providers, family, and the patient are all working from the same coordinated care plan. They all have access to the same information. Basically, they're working from the same playbook. And this can be as complex as sharing information via a very robust health information exchange, or it could be as simple as making sure everybody has input into it a paper copy of the care plan, and of clinical records, medication lists, and anything else that's supporting the person with the disability. So it doesn't require a big fancy health information system. That may make it easier, but you can do it without that. Next slide. This is an actual patient, not one of mine, but somebody that Chris and I became aware of. This is Pedro, who was a 27-year-old from the Dominican Republic who at 17 had a spinal cord injury. He eventually, 10 years later, when he was 27, moved to the Northeast United States because he thought he could get better care, and there was extended family, including his mom, in that area. However, not surprisingly, shortly after he got here, he came to the emergency room. He still had his trach, he had chronic respiratory insufficiency, he had multiple pressure ulcers, he had a urinary tract infection. He ended up hospitalized for this extended period of stabilization, and ultimately was discharged to a nursing facility. Remember, we're talking about a 27-year-old here. And his goal, not surprising, he wanted to live with his mother, manage his own care, get a job, build relationships. He had physical barriers, and he had some behavioral barriers that made this difficult. So as a family physician, as a primary care provider, what could I do to help? Well, he needs somebody who understands how to help someone with a disability, and he needs a care coordinator. He also needs a coordinated group of clinical providers, not just a PCP, probably a physiatrist and a behavioral health provider. He would certainly benefit from peer supports. He needs, obviously, daily personal care. I'm sure he does not want his mother to do that. He needs mobility assistance, and the bonus point, he needs all of this paid for somehow. Therein lies the hang-up for a lot of these folks, is how do we get it paid for? And there's where, as a primary care physician, I need the help of a care coordinator, his insurance company, his Medicaid, his Medicare, whoever it is, to help me find resources for him. Next slide. So what can his new PCP do? Well, all the bullets on this slide are critical, but I think of them in this order. The first thing is my relationship as a primary care doc with Pedro. I have to listen. I have to share his concerns and help him share in the problem solving. Second, I have to maximize his physical and emotional health to maintain his independence. Can I do that as a PCP by myself? No, it's going to take a team, and that team includes Pedro. And then we need to make sure we're proactive at treating what can be treated to avoid rehospitalization for him. We can develop a care plan to make sure that every member of his team, including Pedro, knows how to help with his care and knows what their job is in keeping him healthy and independent. His care plan would address his medical, behavioral, functional, and social issues, everything that could help him be successful, and every barrier that might worsen his experience. However, I have to say that most primary care docs, me included when I was in practice, really we're not used to thinking about care plans beyond the P in a soap note. You know, what's my plan? What am I prescribing? What's my care plan for him? But a true care plan, most primary care docs have no idea what they are. And you really don't want the PCP to develop them by themselves. It's really helpful if a care coordinator or care manager can help to develop a full care plan and can show the PCP the value of the complete care plan, including, I will tell you, how that care plan can make the primary care doc's job a little easier. You know, it's not we're used to just, okay, we see the person, we do whatever, they leave the office, on to the next person. So you have to help primary care physicians understand how a full care plan can make everybody's job easier and benefit the person that they're caring for. It seems obvious to me now, but it sure wasn't when I was in practice. So next slide. Obviously, one of the hallmarks of primary care is an annual well person visit. Now you say, okay, Pedro's not a well person. Well, it doesn't matter. He gets a well person visit because there's a lot of him that is healthy. So standard care, history and physical, sure. Making sure that I, as a primary care doc, know all of his medicines. And in somebody who's seeing 3 or 4 or 5 providers, that can be a challenge. Reviewing the care plan. So that what you want is you want your primary care docs to understand who else is part of the team and how each person is supporting that patient. Obviously, as part of this, also prevention and health screening. I can't forget that just because the person in front of me has pressure ulcers and other medical issues that need to be attended to. Discussion of advanced directives, absolutely. It doesn't much matter what age that should come up in some way and needs to be addressed. And again, remember that that the social determinants of health are critical, and that people of lower socioeconomic status, people with higher social risk factors, are less likely to get appropriate interventions. Next slide. So primary care resources for disability competent care. 24/7 availability is something that, in my life, is something that every primary care practice has. Now, does that mean that the primary care physician, him or herself, is available to this person 24/7? Absolutely not. It means that there is someone available, and ideally, someone who has access at least to be able to read the patient's medical records. So that requires some kind of health information exchange or ability to get onto a medical records platform. Obviously, accessibility for testing, and that may go beyond physical accommodations. If somebody in a wheelchair, it may be you have to think hard about how to get them in for a mammogram. Somebody with quadriplegia, just the prep for a colonoscopy can be a daunting task. But what about the person who has a serious behavioral health disorder and who really can't be alone, who needs someone with them? I know most x-ray techs don't want somebody else in the room when they're doing an x-ray, but you may have to allow for that. Home care, absolutely. I used to say I was the last physician in Maine who still did house calls. But reality, house calls are very difficult to do in a busy practice, and you don't get paid enough to do them. However, it's phenomenally useful to see where somebody lives and how they manage in their home setting, particularly somebody with a significant disability. There are home care medical groups that will do this. Also, home health nursing can be a way of getting clinical eyes on someone who has difficulty leaving their home. And when I say clinical home health nursing, I mean, behavioral health or physical health, really. But seeing somebody in their home who has difficulty getting out or just to understand how they live can be critical. Behavioral health homes can also provide a haven for people with serious mental illness. It may be very difficult for someone who is disabled by serious mental illness to go to a regular, busy primary care practice. And it may be much better if we can find a way to provide them complete care in a behavioral health home. It may be much more comfortable for them, and may be much more willing to participate. Next slide, we're going to start talking about preventive care and health education. And I love this. Health and wellness can coexist with disability. I would say do coexist with disability, and are as important to people with disabilities as those without. But gosh, this gets forgotten all the time. If we look at the next slide, managing my visit. In my practice, we had some patients with disabilities who routinely were scheduled to arrive a half hour before I was scheduled to see them. Or some patients who routinely were not asked to wait in the general waiting room because it was either too difficult for them to be in an area with a lot of strangers or too difficult for them to have the amount of stimulation that might go on in a waiting room that involved kids running around and playing and other people waiting. So being sensitive to the need for additional time or for a quiet space to get ready to see the doctor can be very important. New patients were always booked for longer visits in my practice, whether they had a disability or not. But if I knew, for instance, that someone coming in had a disability that might limit their mobility, I might put them in 2 slots. The first slot would be to meet me with their clothes on, sitting in a chair or in their wheelchair and talking. And then a half hour in which I might go off and see other patients, and my assistant would help them get ready for an exam, and then a second slot for me to come back and do the exam. It is, it just takes a little planning and a little extra time, but it can make it so much more comfortable for the person with the disability. The reality is, in a small practice, which for at least the first 16 years of my practice life, I had a tiny little practice in a town of 4,000 people. Physically accessible exam rooms and exam tables are expensive, and we only had one. We had 4 exam rooms, but only one was really easily physically accessible. So it's critical to make sure that room is booked for the patient at the same time as the appointment. It did me no good if they booked someone like the young man in his motorized wheelchair who routinely put dents in my hallway, unfortunately, because he didn't drive very well. But, to book him for an appointment and then have that room busy with one of my partners doing a procedure didn't work because that was the only room that he could really comfortably get around in. So your front office staff needs to think about that. Larger exam rooms. You might need a larger exam room because you might need to accommodate family, caregivers, interpreters, particularly, say, a sign language interpreter. You can't cram them all into a little tiny exam room that's really meant for just the doc and the patient. Next slide. So what about standard care for people with disabilities? It's something that every primary care provider needs to think about, really regardless of a person's abilities. You need to think about tailoring care to somebody's individual needs. For people with disabilities, including caregivers and family, this can be is really critical. We need to include them, but, and there's an important but, it's important to either ask outright or watch for nonverbal cues that a patient with a disability might not want their caregivers present for the entire visit, and to respect that. A person that comes to mind is a young woman that I cared for she had a pretty significant developmental intellectual disability, and she used to come to the office with her mom, although she didn't live at home. She lived in supported housing, but her mom would bring her to the office, and her dad was actually a family physician partner of mine, and so I had to tread a little bit lightly with them, but her behavior when she would come in with her mom, she would regress to basically sort of 5-year-old kind of behavior and be very difficult. And at one point, it just happened that her mom had to leave the room to do something, and she changed entirely and became much more collaborative with me. She wouldn't talk to me when her mom was in the room. And so I was very frank with her mother, and I said, look, when Christy comes in from now on, you need to stay in the waiting room. I will come and get you if Christy and I think there's something you need to know, but you need to let her come in by herself because she wants to, she knows what she needs to say, and it makes her a much more active participant in her care. But, and that was news to her mom, but it worked very, very well. So including caregivers, absolutely, but also understanding that some people, even if you think that intellectually they're not really able to participate in care, you have to give them that opportunity. Next slide, talking about secondary conditions. Okay, so you have to assume that people may have other conditions beside their disability and they may not be related or inevitable. There may be some that are more likely. For instance, if I'm seeing an adult with Down syndrome, I can expect that weight and obesity may be an issue for them. doesn't mean that it has to be an issue, and it doesn't always mean that it's related. As a primary care physician, having protocols in place to identify and treat secondary conditions is really important. And also screening for secondary conditions, particularly depression and behavioral health disorders. Except for people with intellectual disabilities, depression screening really should be no different than what we do for the general population, and is something that should be part of every primary care visit. Screening tools for co-occurring disorders like depression haven't generally been validated in people with significant intellectual disability, but behavior changes can alert to the possibility of depression, things like sleep disturbance, change in eating, weight loss, weight gain, agitation, and just asking for self-report about symptoms of depression. The other thing that often primary care docs forget is to ask patients with disabilities about risky behaviors. We know that there is a high rate of tobacco use in people with severe mental illness or serious mental illness. We also know that we can't assume that somebody, say an adult with a developmental disability living in a group home, that they don't smoke. In fact, I remember one patient of mine who we really tried to help him quit smoking, and we couldn't figure out, he kept saying he was going to. Well, it turned out that the barrier to him stopping smoking was that it was his aide smoked, and the only time the aide could leave to go outside to smoke was if this young man went outside with him and also had a cigarette. So the aide was sabotaging all of our efforts at smoking cessation because the aide wanted the cigarette. And until we sort of got through that, it was a real challenge. But, you know, you can't assume that someone, even someone who can't lift a cigarette to their mouth themselves, you can't assume they don't smoke, or that they don't consume alcohol, or that they don't have other risky behaviors. Next slide. This section is titled Cancer Screening, but I want you to think about this as screening in general. We know that there are major disparities in access to cancer screening due to disability status. There are major barriers to access to many screenings. And people with disabilities are often underinsured, have less access to health care, more likely, as I said, to engage in risky health behavior. And we know that there are studies showing that people with advanced disabilities aren't getting screened for things like diabetes, hyperlipidemia, colon cancer, breast cancer, cervical cancer, as much as others of their age and gender. And barriers for them include the physical barriers for some to healthcare, cost, healthcare provider discomfort, and just the physical difficulty for some of them. So what do we do about this? Well, certainly making sure that a primary care practice has in place standard prompts that say, whatever this person's disability, they are 50 years old and they should be referred for colon cancer screening. Or whatever the disability, this woman is 40 or 45 or 50, depending on which guideline one adheres to, and she should be referred for a mammogram. And making sure that it's not just the primary care physicians, but their whole office is oriented towards saying everybody gets screened. Everybody gets the appropriate screening tests. And health plans can really be instrumental in providing training and community outreach, and can enlist the help of their primary care docs in their network who are already doing a good job at this to train other people. And it's not on the slides, but before I forget to mention, it's really important to remember that while osteoporosis screening for the general public usually doesn't happen until women are 60 or 65 and men even older, for somebody like Pedro sitting in a wheelchair, he's going to need osteoporosis screening at a much younger age because his bones are going to get thin much earlier than otherwise because he's not using his muscles, he's not walking. So next slide. Is more about barriers to screening and why screenings have been missed. It's important to note that my favorite website is the United States Preventive Services Task Force website. I just love the information there. Well, the USPSTF screening guidelines none of them call for separate screening modalities for people with disabilities. Although they do admit that verbal screening tools, like the ones for depression, might have to be modified with significant intellectual disability, none of the screening guidelines otherwise are different. And that's very, very important to remember. Next slide. We're going to talk a little bit about sexual health because, let's face it, primary care docs avoid talking about this with anybody. But even in spades, we avoid talking about it with people with disabilities. And so there's lack of information, unassessed needs, or untreated needs. If you go to the next slide, think about it. People with disabilities have the same needs and desires. You need to do a sexual health history and need to offer education, screening for sexually transmitted infections, and birth control. Also really important to be aware that particularly for women with physical and intellectual disabilities, they may have been sexually active, it may not have been consensual. And think about our patient Pedro. He had a spinal cord injury when he was 17 and became quadriplegic. We can't assume that he doesn't have sexual desires, and we can't assume that he wasn't sexually active before his injury. So as his primary care doc, I would have to think about that and ask about that. In fact, I would think that some of the acting out behavior might be because he's angry that he's sort of lost his manhood. So as a primary care doc, I would need to open the doors for the discussion, find out what his thoughts are, open to what his sexual orientation is. I don't know if he's gay or straight. Need to ask. He's probably not been open to his mother about his sexuality, both because he's a young man and because he's a young Hispanic man. And he might not want to talk to me, but he might want to talk to a peer, someone else with a spinal cord injury, similar age, who's been through what he's been through, who could help him. But if I don't bring it up as his primary care doc, or somebody doesn't bring it up, his care manager, somebody, then he's just going to think nobody wants to talk about it. Next slide. Actually, you can go right to 25. We're going to talk a little bit about primary care network and accessible offices. I'm not going to say a lot about network. Disability-confident primary care was certainly not something that I was taught in medical school. In residency, I remember we did have one session on sexuality and disability. It was actually very good, but it was 1 hour out of a 3-year residency. So most of what I learned by listening to my patients and their caregivers, being open to suggestion and correction when I messed something up, and remembering to look and speak to the person, not the disability. So in a practice, this is something that we can help get developed. There's often somebody in a PCP's office who has experience with people with disabilities, either in their family or in prior work, and has expertise to share. Practices can also, if they really are interested in becoming more disability competent, they can ask some of their patients with disabilities to participate in focus groups or work groups to help them improve their disability competent care. Next slide. So you'd like to know, you'd like to be able to identify your disability competent primary care docs or practices. It's not very easy. You can't really, beyond knowing that somebody is complying with all of the ADA rules, it's pretty hard to identify who's truly giving disability competent care and who isn't. Over time, in whether it's a plan that owns the network or a plan that contracts with physicians, over time, care managers, care coordinators, provider services people, and your docs they'll figure out which practices are both more willing and more able to care for people with disabilities. We'd like them all to be participant-centered. We'd like them all to be responsive and accessible and collaborative. Remember that for people with disabilities, as really for all of our folks who are dually eligible, we want them to have an interdisciplinary care team. We want everybody to get together around this person's care and make sure that they're getting what they need and what they want. That's a stretch for a lot of PCP offices and takes a lot of work. So that's something that as health plans, we can help our practices. One of the things I did with one of our practices was we actually gave them a survey to do. We used SurveyMonkey because it was easy, and asked everyone in the office, from the front office staff to the docs to everybody, just to talk about how comfortable they were with various disabilities and how much they felt they knew about how to help them and where they thought the barriers were. The next step to that was to be working with them on basically a performance improvement or quality improvement project to include everyone in the practice and some of their patients with disabilities to help them do better. If we're going to do that, we need to help them get better, and then we need to reward them for doing it. Next slide. What about using primary care practices? Again, health plans need to be willing to help them to develop the quality improvement process and give them the data they need to do it. And again, I think practices need to remember that it goes way beyond the docs and the nurses and the clinical people. And when somebody with a disability contacts a primary care office, who do they talk to first? They talk to the receptionist. If they have difficulty speaking, if they have a behavioral health issue that makes it hard for them to talk to somebody and express their needs without either sounding angry or sounding as if they're sort of having a hard time. If you have a very engaged parent of an adult with disabilities, maybe a little bit too engaged, it's the front office staff who have to cope with that. So we need to help from the beginning to the end to make this a better process. The next slide talks about accessibility, and again, provider directories. Your provider directory can tell somebody if an office is accessible, physically accessible. It'll tell them if an office has co-located physical and behavioral health. But who's really good at it and who isn't, that takes time to figure out. Physical accessibility and co-located behavioral health care can be useful markers for a practice that's paying attention to being disability competent. Lessons learned from participants and their IDTs, absolutely. So this becomes a process that has to be a little bit developed over time. You can't just make a list and check off and say, here are the really disability competent practices and here are the ones that aren't. It takes a little time to figure that out. Now the next set of slides, and then I'm pretty much done, the next set of slides are titled Pain Assessment and Management. So if you go to slide 29, I think that really what we're thinking about here is pain as a symptom. So when I look at these slides, I'm thinking, okay, yes, pain, but think of this as any symptom that may be expressed differently in someone with a disability. There's been a hypothesis that people with disabilities do experience more pain with greater severity than the non-disabled population, but not a lot of data to support this hypothesis. So it's really what I want people to think about here is that awareness and expression of many symptoms, including pain, may be different in people with some disabilities. And the next slide, we talk about kinds of pain. Skin breakdown, sure, although in our gentleman Pedro, who is quadriplegic, he'll have skin breakdown without pain. And we know that people with severe cognitive impairment and pain may have huge behavior issues. It may be very difficult for them to function until we treat their pain. And the one person that comes to my mind was a young man. He was, I think, about 30, severely developmentally disabled and intellectually disabled. And his caregivers would recognize behavior changes in him as indications of pain. I have to tell you, they were incredibly good at this because I couldn't tell. He seemed the same to me, but when they came to me and they said, no, David's acting differently. There is something going on and he's got pain somewhere. Usually he turned out to have an ear infection or a strep throat, and they were rarely wrong. Almost always, if they said he's different, then they were right. He had no way of telling us. He was nonverbal, but for the people who paid attention to them, he was obvious. And then we think about Pedro. He might not feel pain from his skin breakdown or if he injured himself. But what about pain that he does feel? Headaches, neck pain, he might have some upper extremity pain. He might not be able to help himself when he has pain. His emotional and behavioral responses will be colored by his physical disability and his culture. So as his PCP, I would need to think not just about his disability culture, but his Hispanic culture and how that colors his approach to almost any symptom. Next slide. A little bit more about pain, remembering that everybody experiences pain differently, not just people with disabilities. And everybody functions differently with pain. You know, we all know them. Some people go right to bed the minute they have a headache. Some people keep on going when they're in the middle of a heart attack. And that pain is tied in with how our attitudes toward pain, our beliefs about pain. I think the biggest thing, particularly for folks with some folks with disabilities, is helping to educate them about causes of pain or other symptoms, what they can do about it, helping them to feel as if they have some control. If you feel like you have some control over a symptom, it's much easier to cope. Not always totally easy, but much easier. Social supports. Do they have in their lives somebody with kind of a positive outlook and a positive attitude who will support and help them? Exercise, absolutely. And again, you know, some people, not just people with disabilities, but in this context, they may see pain as a sign that they should do nothing, that they should stop doing something. And that may, in fact, not be the case. However, in folks with disabilities, whether they're physical, intellectual, emotional, our standard physical therapists, exercise professionals, fitness people may not really be ready to help them in a way that they need help. So in this case, if as a PCP, if I were referring someone with a significant disability, say, to physical therapy, I might want to call that physical therapist and prep them a little bit, tell them a little bit more about this person and how to help them. You know, explain to them what my understanding would be and understanding with the patient about how they're going to approach this intervention. The next slide just talks about pain management plans, and what it doesn't say, but which I think is understood, is that this has to include the planning for how to manage pain, whether it's acute or chronic, has to keep at the center of it the person with the disability, the patient that's sitting in front of the primary care doc. The strategies have to be developed together. The interdisciplinary care team may want to weigh in. Everybody has to be on the same page. Next slide. So here's Pedro, and this is true 5 years later. He was 32. He was living with his mother in subsidized housing. He did have personal care attendants. He was independent. They did get him a power wheelchair. He had peer support. He continues to have problems with skin ulcers, but again, being proactively managed. So rather than waiting till they're huge and he's in the hospital, noticing them and treating them beforehand. And he is stronger. He wants to start driving. So what's my job as his PCP now? My job would be to see him regularly, be proactive about prevention and treatment of his chronic problems, make sure that his IDT, that I'm part of his IDT. Now, realistically, in a busy primary care practice, can I attend a 1-hour IDT once a month? Absolutely not. Can I call in for the last 5 or 10 minutes? Sure. Can I send a clinical person from my practice or at least have them on the phone? Absolutely. Can I make sure his care is coordinated with his other providers? Yes, I absolutely should. Make sure I pay attention to standard health maintenance and screening for him as he gets older. And make sure that I am, again, looking at Pedro, not at a guy in a wheelchair. So in conclusion, and just there's a summary on slide 35 for key takeaways. I think, I don't need to read them to you. I think that what's critical is making sure that there is a team approach to care for people with disabilities, and that we take the time that's necessary to make the teams functional, and that at the center of the team is the person that we're trying to help. So I will stop there, and I believe I have left us at least 14 minutes for questions.
Participants are welcome to submit questions in the chat box. Type your message in the lower corner and then press enter on your keyboard to send it.
Well, thank you, Dr. Chamberlain, for that great presentation. And you're right for leaving us 14 minutes for questions here. So our host here did mention, please, any content questions that you have, enter them in the chat box on the lower left-hand side of your screen. So we do have a question that's come in already. And Dr. Chamberlain, if you're able to answer this, I think we'd love to hear from it. Are there any organizations or agencies that can provide lists or resources of PCPs that work specifically with individuals with disabilities?
I would suggest that in most states that I've worked in, there are disability advocates, and they will usually know. So the advocacy organizations usually know who's out there, who's good, because they hear it from the people that they're dealing with. I wish I could tell you that local medical organizations, hospitals, or even health plans would always know the answer to that question. They don't always, but I would look to the advocates to give you that answer or to give you some information.
This is Chris again. I agree with what was being said. I also appreciate what Ben typed into the chat about some things in California. Once again, they're leading us on this issue. The other thing that we would do is, over time, our care coordinators would hear from their clients what worked well with primary care doctors and what practices were the most responsive. And so slowly over time, a community, whether it's the advocates, whether it's the plan, whether it's the care coordinator, word kind of spreads, because there is no, as Dr. Chamberlain said from the beginning, there is no database that really gets at disability competency. It may get at some components of accessibility, but it doesn't really get at competency.
And you know, that's where, when I said you have to reward the practices that do, you do have to reward them, because realistically it takes more time. You know, in my busy practice, I could probably see 30 or 35 people in a day, 40 if I worked really, really late. But if half of them had significant disabilities, then I would see 20. I can't live on that. Well, I can, but it wouldn't be great. So I think, you know, if a practice sort of steps up and says, yes, we want to be good at this, we think this is important, this is a mission for us, then we need to reward them in a lot of ways, and certainly financial is one of them. Also helping them out, helping them with maybe some help with getting more accessibility equipment, or more education so that they can do things a little more efficiently. But we need to reward those practices. And I think somebody asked about routine dental care. That is a huge problem, particularly for people with significant physical disabilities. There are some resources, and I will have to see if I can, I did not think about this for this presentation, but there are some training programs available to help teach the dentist, the patient, and the patient's caregiver how to get through a dental visit. A dental visit for somebody with significant behavioral or intellectual disability can be terrifying. And there are actually training programs to help with that. And again, you know, dentists don't come out of dental school knowing how to help somebody who's scared to sit in their chair. At least in my practice, I had one man who wouldn't come in the exam room, but I could sit on the floor with him in the hallway and do most of what I needed to do. You can't do that in a dental office. But there are some resources out there to help those dentists who are interested and willing to learn.
What I've heard in a couple different states over the years, Dr. Chamberlain, is sometimes the FQHCs, Federally Qualified Health Centers, will know of, either have a practice themselves, dental practice, who has some competency, or will know, so that's a good resource. The advocates in the community, or I also have heard of a couple university dental programs where they are willing to do some specialized care, some of which may actually even require a general anesthetic. So those are just a couple places to start. Though again, these are local answers. You can't answer it on a national basis.
Right.
Another question that has come in is, I wanted to get back to rewarding primary care practices. Other things that I've seen and heard is some plans are willing to, with a portion of their members, give a PMPM, in other words, a monthly capitation to the practice to serve certain participants. And what that means is the doctor has more dedicated time. That's a model that's actually been fairly successful in geriatric care. The issue is, how do you figure out which individual? Another thing I've heard is some coding that can be done for longer appointments that then reward the practice. So there's a variety of strategies, and we'll, if we can come up with any more, we'll send it out with the links. You mentioned early about physiatry, Dr. Chamberlain. If you could briefly explain the role of physiatry, geriatrics, and primary care, and how they all fit together or don't.
Okay. Well, when I say primary care, if I'm thinking family physicians, then they're doing geriatrics in their practice. It's not a separate specialty. If I'm thinking primary care internal medicine, they're also doing geriatrics. Obviously, primary care pediatrics not. Physiatry really cuts across all three groups because physiatrists have special expertise in helping people with physical disabilities, helping figure out what the best mobility equipment might be. A prime example of this actually was, I think I didn't make the state very happy. I was helping a state with some review of needs for some of their kids. It was a 2.5-year-old with spina bifida, so he was paralyzed from the waist down and was in a wheelchair. And they wanted to get him a motorized wheelchair, and they had video showing that he could run it. Well, the motorized wheelchair was a $20,000 ticket item, and so I called up a pediatric physiatrist in Boston and said, tell me about this, because I said, from what I can read, this child developmentally needs to be independent. He needs to be able to interact with his peers without his mother or his teacher pushing him over in his wheelchair and putting him on the floor with them. And he said, you're exactly right. He said, we know that small children who are physically disadvantaged need to be mobile enough to be independent, or they don't learn the developmental skills that they need to grow up. So I told the state they had to supply him with a $20,000 wheelchair. I was not, I don't think, on their Christmas card list that year, but I think he got what he needed. But I would never have known that if I hadn't called up somebody with some expertise in physiatry, and particularly in pediatric physiatry. So sometimes it's a matter of co-caring for a patient. Sometimes it's just a matter of calling up and asking the right questions.
That's also a great example of the role of advocacy of either primary care or primary care saying, I don't have the time to follow up on this, by handing it to another team member. Here's some research I showed. This is what I've learned out of talking with a specialist in Boston. Will you keep pushing this on through? Bottom line is, if he's your client or she's your client, you have a responsibility to do what Dr. Chamberlain did, and that's a great example. That's a great example. Here's another question that came in, and I certainly hear this a lot. and that is this person who describes himself as a care coordinator who finds that primary care doctors are often resistant, and that's certainly I would hear from my staff in Minnesota, to their participating in appointments with this care coordinator's members. Do you have ideas there?
Amen. Amen. Yeah, I do. I think the first thing is the primary care doctor may have no idea who this care coordinator is and why they would want to participate or why they should speak to them. You also have to remember that primary care offices are designed to keep the doc busy seeing patients and not doing other stuff. And so as a care coordinator, if you call a doc's office, it's unlikely that they're going to put you through to that physician. And I used to use, when I was a chief medical officer for a plan up in Maine, I said, fine, then I'll call them because they'll put them on the phone for Dr. Chamberlain. And then I would have the care coordinator sitting right next to me. I think there's a little pre-work that needs to be done. The other thing is that a patient can have anyone they want in with them. If a patient says to their doctor, I want this person to come with me, there should not be any discussion about that. There might be, but there shouldn't be. I think the real key is helping physicians understand what your role is and how you can actually make their job easier. The first foot in the door is often, I can help this person so they stop being late for their appointments or missing appointments. If you do that, they will love you. If you can, or I will help this person follow up on the things that you suggest after the appointment. Those are the two really frustrating things. Somebody has Medicaid, Medicare. They're reliant on public transportation. They show up an hour late for an appointment. Do you see them? Do you not see them? Or somebody with a serious mental illness for whatever reason is having a bad day, doesn't show up. If you can say to them, I'm here to make sure they get to you, that really helps. I'm here to help you be more efficient is sort of what you're saying to them. It's still a battle, and I think sometimes, fortunately or unfortunately, what it takes is some doc-to-doc conversation to say, hey, seriously, these people this is what my folks can do for you, so please let them in the door. You will find some physicians who are just never going to be welcoming, and I would say the other side of that is make some friends with some of the other people in the office. Make sure that the front desk knows who you are, that if the physician has a medical assistant or a nurse that they work with, that they know who you are. Sometimes you just have to be persistent. And as frustrating as that is, I wish they would all be welcoming, but they're really looking at you going, how are you going to make my job harder? How are you going to make this take longer than it ought to? And so if you can show that that's not what you're there for, I think it will really help.
Thank you, Dr. Chamberlain. There's also some resources that we dropped into the chat earlier on that might be helpful with this. And there's one that's about to come out of a kind of tip sheet for care coordinators that was developed by a plan in Minnesota that they gave to their care coordinators on how to introduce themselves to the doctor and be supportive in the appointment. And we'll try to get that link up to people if it's not up already. But I'm afraid I need to bring this to a close. Our time is up, and we tried to stay to the timeline. So we're going to have to wrap it up. Please send any feedback you have to the RIC@Lewin.com and answer the survey that will appear on your screen at the end of this webcast. Again, I'd like to call your attention to the resources we have online that I just mentioned, including the Disability Competent Care Self-Assessment Tool. Please join us.
And I will say, if Chris, if you get questions or comments from people that you think should come to me, I am very willing to have people contact me directly or have you send stuff and I will then contact them.
We would love to have you put you in direct contact because then you can understand their question better than going through our brains. So I appreciate your willingness
I'd love to do that.
Mr. Chamberlain. Next week, we'll be talking about care coordination in particular. The presenter will be Rachel Stakem, Senior Vice President for Care Coordination at the Independence Care System of New York. I'd like to thank you again and the Center for Medicare and Medicaid Coordination for sponsoring this webinar and the entirety of the Disability Competent Care work. Thank you for attending.